for completely confusing me, but that woke me up. And I think a lot of food for thought in terms of what he talked about. But I'm following in the footsteps of giants, and there's another giant following after me, so stay awake. There's going to be some interesting information. So one of the questions today was, how do I optimize oxygenation? I clearly have a certain way I do it, but I'm going to share quite a bit of information about the background of why we do it the way we do it. Now, that's the British way of doing it. That's the American way of doing it, the Z or the S, whichever way you want it. But the learning objective today is to really understand the challenges and solutions to oxygen transport and delivery. Because once you understand that, you're going to be able to really figure out how do you optimize oxygenation in a patient. The definitions we need to know about is when you do a blood gas, the PaO2 is your dissolved oxygen in plasma. I know there are a lot of students here, there are several seniors too, but just as a reminder, when you measure the PaO2, you're checking the dissolved oxygen in your plasma, which is usually about 80 to 100. The SaO2 is the percentage of available oxygen bound to your hemoglobin with a normal range of 95 to 100, and almost 98% is available, it's tissue delivery bound to the hemoglobin. And the SpO2 is a non-invasive measure of your SaO2. Every time you get a blood gas, you get all these readings. Now, this is the rest of my talk. Just kidding. No, we really couldn't even get into that. But essentially, respiration and oxygenation involves all this. And you've seen several slides from the previous speakers in terms of how you can actually oxygenate a person based on the physics and the physiology of the normal human anatomy. The key concepts which have also been mentioned earlier include concepts of dead space, which is no blood with airflow, shunt, which is blood flow without air, the ventilation perfusion mismatch, and the concept of hypoxic pulmonary vasoconstriction. I'm sure all of you know this, but if you can remember these in your bedside, I'm talking about at the bedside, think of your patient in terms of these four concepts. Now, this is something I tried to make. I'm not sure you can see it very clearly, but assume you have a patient with a low PO2 or a low oxygen saturation. And then you end up with getting a history. And a lot of times the history is going to determine how you optimize this oxygenation. So you want to figure out, is this acute? Did this just happen? Is this somebody with pulmonary embolism? Is this somebody with a pneumothorax? Is it someone with acute congestive heart failure? And did they just aspirate? Based on that history, you can go to the next steps. Is this someone with a chronic lung disease, for example, COPD, pulmonary hypertension, interstitial lung disease, a neuromuscular disease? Or is this someone who has acute on chronic, which is someone with ILD with an exacerbation, someone with, say, pulmonary hypertension who had a sudden spike in pressures, or is this someone with a COPD with an exacerbation? So you have to kind of figure out in your mind, what am I actually dealing with? Is this a new problem or an old problem with a new presentation? And then you move on to your goals of care, and your goals of care are optimizing the oxygenation and then adapting to the oxygen level, as well as sometimes the altitude, and of course, lastly, the availability of resources at your setting. You then move on to how do you fix this problem. You might involve non-invasive ventilation. You might think about high flow oxygen, which we talked about. You might use PEEP, recruitment, positioning, proning, and of course, advanced support, including things like ECMO. Lastly, you want to look at ancillary measures, including manual bagging, suctioning, positioning, fluid balance, and evaluating your tube in your airway. So this is a quick overview of what you would do at the bedside, and this is how I approach it. We'll switch a little bit into a little bit of physiology, not philosophy, physiology. And the air, as you know, which was mentioned earlier too, is about 160 millimeters of mercury. As you know, the normal atmospheric pressure is 760 millimeters of mercury. What that really means is that on top of all of our heads right now, there is 760 millimeters mercury worth of air sitting on top of our head. Out of that air, 21% is oxygen, rest is nitrogen mostly, and then that makes it 160, 150 at your mouth. And then as Dr. Arindam showed, it drops down in a stepped out fashion all the way to your alveoli and drops down to about 80 to 100, and then depends on arterial or venous side. Now, the blood supply then of course depends on where the blood goes, and the capillaries, especially the pulmonary capillaries, the flow is pretty small, kind of slow, but the surface area is huge, which gives you the place where the gas exchange can happen. And if you look at the mismatch concept, on the left side you can see that the low VQ mismatch. So the low VQ mismatch where there is a normal perfusion but impaired ventilation versus a high mismatch where there's good ventilation but no blood flow. It depends on what's going to happen to your airflow. The normal matching is what the adequate perfusion and ventilation which happens in the alveolus. This is the area which is going to determine your adequate blood flow and adequate oxygenation. Now, oxygen levels obviously vary. Now, this is on obviously on Mount Everest about 33% oxygen. PO2 is obviously very low. Down to the highest human habitation in Peru is about 55% oxygen. People have adapted to these environments to actually live at a low FiO2. and obviously when you're at sea level, you're 100% oxygen. So it's important for us to realize that although we are dealing with a room air normal pressure, this can vary depending on where you're located. Now, this is a curve which most of us probably dread, but if you can actually at the bedside, I'm talking about, this is what I think of at the bedside. I'm trying to get in my head, what is the O2 dissociation curve at this point? So as you might recollect, PO2 and saturation. Remember this, 60% saturation is about 30 PO2, 90% saturation is about a PO2 of 60. And then the curve moves to left and the right depending on your pH, your 2,3 DPG as well as 2,3 BPG and your temperature. Now, what this really means is that if the curve moves to the right in a situation of temperature, fever, acidosis, it's easier for the oxygen to be released. If the curve moves to the left, the oxygen is bound with more affinity and it's harder for the oxygen to be released. Now, if you look at the other curve, which is adult hemoglobin, fetal hemoglobin and myoglobin, there's something called the affinity of oxygen. The myoglobin is has much more affinity for oxygen. In that situation, what happens is that you're going to be actually moving oxygen from your lung into your muscle, which is actually a very good physiologic adaptation because that's where the oxygen needs to go. Now, in terms of shifts and slopes, if you have a right shift, just as I said, there's more oxygen available. If you have a plateau phase of the curve, that's where your pulmonary capillaries are present and they actually carry more oxygen. If you have the steep slope, that's the systemic capillaries which actually release oxygen, and the curve is shaped that way because of the concept of cooperativity, where the affinity of the hemoglobin molecule for oxygen increases as one molecule attaches, the second molecule, third and the fourth. So this is something which you can actually think about at the bedside when you're actually taking care of somebody with hypoxia. Now it's called 2,3 BPG now, it's no more 2,3 DPG, and essentially as the production of 2,3 BPG increases, it's adaptive. It increases when there's diminished peripheral tissue oxygen availability. High levels shift the curve to the right as in childhood. Low levels cause a leftward shift. When the production increases, you're going to have less affinity for oxygen. So it's good to produce the BPG. You can look at the physics of this, pretty interesting actually, on how the BPG molecule actually acts as something called a heterosteric allosteric modifier. So it actually makes the hemoglobin molecule shift in shape. Now, there's another concept called the P50, which is the 50% saturation of hemoglobin with oxygen. A higher value of P50 means that you have lower affinity and more available. Now, for example, for hemoglobin it's only 3.5. For myoglobin it's 130. So this allows oxygen to move to muscle in a hypoxic situation. Now, this is another moving to a clinical situation of a very simple way to optimize oxygenation. Clearly, this patient has had a collapse of the left lower lobe of the lung. The heart has shifted to the left. In this situation, you want to turn the patient in the right direction, and we'll talk about what the right direction could be. In another patient with obviously destroyed lung on the left, pleural effusion, atelectasis and collapse of the right lower lobe, you also want to figure out what can I do for the patient's position in terms of optimizing his oxygenation. Always remember the good side is down. As much as you can, good side down unless bleeding. Of course, exceptions are there, but almost always keep the good lung down so that due to gravity as well as perfusion, you send the blood to the good area. Of course, one good turn deserves another, and this is the concept of prone ventilation, which we'll come to later. Now, in terms of the newer concepts of oxygenating, they did a study of doing a non-invasive ventilator to a patient who was getting intubated. They were actually intubating the patient, but they left a nasal non-invasive ventilator on during the process of intubation. And while they kept that on, they actually noticed that the facial mask, the PO2 was about 88, the SPO2, and the PO2 was about 88 or so, and then they actually noted that there was no loss of PO2 once they had kept the NIV on. So this may be an interesting bedside thing for you to try when you're trying to optimize oxygenation during the process of intubation. I'm not sure how practical it is, but it may be something to think about if you're intubating somebody. Never lose PEEP, never hyperoxygenate, never break the circuit, never turn to the wrong side. These are some nevers which you want to think about all the time. And this is a formula which you can think about at the bedside also. Oxygen delivery obviously depends on how fast your heart's pumping, your oxygen content, your saturation and dissolved oxygen. So you can manipulate this number, you can manipulate this number, you can manipulate this number, and at the bedside you can look at those concepts. Now, top 10 nasal cannula positions. Usually it's bilateral intranasal, but often they put it in the mouth. A lot of them have it as a fashion accessory around their neck. Sometimes it's a forehead band for cooling off perhaps, and rarely you can even have it on the bed rail or disconnected. In my experience, most common location is disconnected. So make sure that to optimize oxygenation, your patient is actually connected to the oxygen. Now, Arinda mentioned this earlier about the nasal prongs. Quick formula, which I'm sure all of you know. 1 liter per minute is 24%, 2 liters is 27, 3 is 30. So you add 21 plus 3 for each time you add a liter of oxygen. Now, in terms of suctioning, when you're suctioning somebody, you need to hyperventilate them, and you may need to hyperoxygenate them just before suctioning. You have to think about doing it for less than 15 seconds. Avoid saline lavaging, and also continuous suction is better. Keep your suction catheters small. Now, the risks obviously include, which you've all seen at the bedside, bleeding, hypoxia, atelectasis, etc. Now, I'm not going to go into this, but this is what's happening at the tissue level, and carbon monoxide, as you know, is much more bound. In a situation of carbon monoxide poisoning, you may have to think about situations like doing hyperbaric oxygen to treat carbon monoxide poisoning to optimize oxygenation. This is a sublingual image of the circulation, and this is where it's all happening. And at the bedside, we really haven't gotten the point of actually using this information, and it's still experiment in my opinion, but probably in the future we'll be able to use this to improve on the really delivering oxygen where it's required, which is at the cytochrome level. Switching briefly onto ARDS. Now, you need to avoid hyperoxygenating ARDS patients, mainly because this is something new which I didn't really think about that much before. You can get alveolar denitrogenation and absorptive atelectasis. Apparently, the absorptive atelectasis is very difficult to reverse once it sets in, and that is why you want to try to keep weaning down the FiO2 to the lowest required. So the 70% is much worse than the 60%, which is much worse than the 50%. So if your patient doesn't require a higher FiO2, try to lower it down. Remember, the ARDSNet trials really were 55 PO2. So now the toxic oxygen species also actually develop very quickly. You actually start getting them fairly rapidly, within hours, the superoxide anion, and they can actually cause a fair amount of damage to your airway. Now, a low tidal volume will promote atelectasis, especially without adequate PEEP or size. This study in the AJRCCM in 2000 actually showed, they experimentally showed that the pulmonary gas exchange response to oxygen breathing creates atelectasis. There may be, Dr. Ram had shown the neuromuscular blocking. It does help in patients with severe ARDS. You have to treat the dyssynchrony and obviously adequate sedation. Prone ventilation, ECMO, doing diuresis if you need it, and also secretion clearance also help. There are some experimental rat studies of antioxidant usage. Now, we talked about using a little more physiology before we conclude. In talking about wasted ventilation and things like the Haldane effect. Now, carbon dioxide obviously shifts the curve to the right, and then you actually, oxyhemoglobin binds CO2 less avidly than deoxyhemoglobin. That allows you to actually get more oxygen. So the reason we're doing all of this at the bedside is to make sure that you optimize both your CO2 levels and your oxygen levels. Now, with age, you do lose your PO2, it does drop, and in that setting you may have to tolerate a little lower PO2 and a little lower saturation. And in terms of, this is a very old study from 1974 which actually proved the absorptive atelectasis, and they show it's very complex physiology. We can talk about it after the talk because of lack of time, but HPV actually changes as you give oxygen. And when you have this old adage that in COPD patients don't give too much oxygen, this is what's happening. You're actually reversing the hypoxic pulmonary vasoconstriction and worsening your oxygen delivery. Now, we know about PEEP. It does prevent alveolar derecruitment and also lowers the right to left shunt fraction. You can also have the recruitment method. There's just one method to do it. Amato in the old study from 98 showed the concept of the ideal PEEP, and if you just look at his numbers, you can actually see that the PF ratio improved actually with every hour. This was 1 hour, this was 36 hours, this was a week later. So you actually improved the PF ratio with using protective ventilation. Now, the goal PO2 we talked about is 55 to 80. Now, a higher PO2, higher FiO2 is to be avoided. You also want to decrease oxygen consumption, and that you do by managing your fever, sedation, anxiety, and respiratory muscle use. You also need to optimize hemoglobin to about 7 or so. Most people I've seen are doing it even above 7, but you know, the evidence is there only to be used. If you don't use it at the bedside, it doesn't make any sense. So ideally, don't transfuse if you don't need to. And of course, nitric oxide has also been talked about. There's a nice schematic. If you can look up this article, look it up. It's a very nice way of looking at the way the prone ventilation helps. They're talking about the lung units, and then they talk about how you have the ventral, which is the top, and the dorsal, which is the bottom. There is shape matching. With gravity, the top becomes bigger, the bottom becomes smaller. The red is the blood flow, and you can see the blood flow is more in the bottom. And once you turn to prone position in several minutes, and as time progresses, what happens is that this supine adapted position quickly changes and doesn't go away for a little bit of time, and the blood actually continues to flow to the better aerated areas. And as you kind of change the pressure on the alveolar units, you're actually making them more uniform in shape. So this is a very interesting way to look at what prone ventilation does. And this is also showing you how the pressure of the heart on the segments here, there is so much area that is occupied. When you reverse them, the pressure on the actual lung units goes down. So this is another way to optimize oxygenation. Now the PO2, which is taken from the up-to-date series of database, you can actually see that the course of the PO2, the PF ratio actually drops and improves, but in general it's going upwards. The prone study obviously showed a mortality benefit from the NEJM recently, which showed that the prone group does have a benefit. And this is another CT which was showed earlier by Dr. Ram, where increasing the PEEP actually improves the aeration in different areas. Now this is a quick concept of driving pressure, which is delta P, which is a tidal volume by compliance. Again shown in an NEJM article that this improves your functional lung volume. The functional lung volume is not the same as your predicted lung volume. It's the actual part of the lung which is participating in gas exchange. So this is a concept that is also, I think, going to be applicable at the bedside. Nitric oxide, not easily available, but essentially what it does is it improves the blood flow and improves your VQ. Prostacyclin can also do the same thing. Fluids, Dr. Ramesh will hopefully talk about that, just have a little bit of patience. And liquid ventilation, Cochrane review showed no benefit. Theoretically, you might cause something called liquid PEEP. The liquid actually kind of goes and opens up the airways and the alveoli. So does oxygenation save lives? Just the last 3-4 slides will conclude. Neuromuscular blocking, as you saw previously, helps your PF ratio. Recruitment helps your PF ratio. And recruitment maneuvers actually save lives in the ICU, at least in the ICU. I didn't say they leave the hospital. They at least live in the ICU. So concluding, so your low PO2, low saturation, get the history, triage as to acute or chronic. At the bedside, think of what they showed up for. Try to fix your optimal goal of oxygen PO2. Do you want to use a low PO2 or a higher PO2 for your patient? Think about the O2 dissociation curve as something you can actually apply at the bedside. Optimize your hemoglobin if you can. Use the different recruitment techniques available to improve your oxygen delivery. And then finally, of course, use ancillary measures including the PEEP as well as suctioning. Never stop learning, because life never stops teaching. And I was telling this to my son and he reminded me, but you got to use your learning. So whatever you learn, try to use it. And of course, prevent hypoxia, do not smoke. Thank you.